Hi, today I'll discuss about latest advances in desmoid tumors and how we have progressed in our clinics in AIIMS in last few years. So it's a very rare disease and happens usually in younger people. It causes pain, deformity, contractures, and the symptoms depending upon site. It might cause limping, it might cause lump, and it might cause difficulty in range of motion. It might lead to feeling of isolation, depression, interruption of education, employment, and also is cause of long-term opioid use in younger people. So as I told, the peak age is 30 to 40 years. Females are more commonly affected than males. And in a syndrome called familial adenomatous polyposis, in which colorectal cancer risk is very high, it develops in almost 5 to 30% of people. And it is apparently the most common cause of death in familial adenomatous polyposis, which is a genetic syndrome after colonic cancer. So usually it might happen anywhere in the body, most commonly in extremities and abdomen. However, in people with familial adenomatous polyposis, it happens more commonly in abdomen. And as you can see, 80% are intra-abdominal. The pathway which is implicated in this tumor is beta-catenin pathway, and beta-catenin mutation is present in almost 90% of people. So this is linked to cadherin pathway, which is there for cell-to-cell adhesion. And this beta-catenin is usually bound to destruction complex. Destruction complex is made up of APC, exin, CK1, GSK, and PP2A. So what usually happens is that it is once beta-catenin is phosphorylated with the help of CK1 and GSK, it is degraded by proteasomes. But in case it is not phosphorylated and there is some mutation in beta-catenin or APC, then it goes into nucleus where it binds to T cell factor and causes increased transcription and hence leading to cell growth and cell replication. So the most important thing is pathology confirmation by expert pathologist. And the hallmark, though it's not exclusive to fibromatosis, but the hallmark is nuclear accumulation of beta-catenin. Almost 90% of people, adults, will have beta-catenin mutation. This is how beta-catenin IHC looks like. So mind you, beta-catenin immunohistochemistry is different from beta-catenin mutation. Immunohistochemistry is by stain, cellular staining, just like it can be seen in this. However, beta-catenin mutation is at genetic level. So I'll just tell our experience. So of 102 people, which we included in one study, almost 50% were misdiagnosed as something else. And the common misdiagnosed or common mimickers were neurofibroma, nerve sheath tumors, solitary fibrous tumor, and others like angiofibroma, nodular fasciitis. So the importance of beta-catenin mutation, which is also known as CTNNB1 mutation, might be manifolds. So in case there is no beta-catenin mutation, that it should raise suspicion of familial adenomatous polyposis. Also, the kind of mutation depicts prognosis. Just like there is something called T41A, which has good prognosis, S45F, which has poor prognosis. So I'll just tell you about how this familial adenomatous polyposis looks like. So this was a patient who had previous surgery for colorectal cancer, and now he came to us with multiple abdominal masses. On biopsy, came out with fibromatosis. And as you can see, the APC mutation was positive. And this was his kid who had multiple inclusion cysts, these kind of cysts, which are present in familial adenomatous polyposis. So this boy is right now under screening for familial adenomatous polyposis so that he does not develop colorectal cancer. Or if he develops colorectal cancer, we are able to do preventive colectomy. This is again, his mutation is also positive. So what is the current guidelines that dictate that mutation testing should be done or not to be done? So the Desmoid working group recommends strongly doing mutation analysis in desmoid tumor. What are the treatment options? So these are the list of treatment options, and any one of them can be chosen by the expert team. So there was a time in 2011 when the guidelines used to say that surgical approach is the right approach, primary surgery, upfront surgery. However, with time, this thing has changed dramatically. Now, surgery is no more standard of care for desmoid type fibromatosis. So, which site can be an exception? And as everyone agrees, abdominal wall, small tumors, which can be taken out with a great margin, might be the exception for this case, as 90% of these tumors don't recur. So, we will not go ahead with surgery in first line, except if it is a small fibromatosis, abdominal wall, and can be taken out with ease. Again, desmoid tumor working group recommendation: if a patient is diagnosed, active surveillance, which means MRI after every 2 to 3 months, can be done because some of them regress or have stabilization by itself. I'll come to that. In case it progresses, then probably for abdominal wall, surgery might be contemplated. However, for intra-abdominal, retroperitoneal, extremity, girdles, or others, medical management remains the first line. So why it behaves differently as compared to soft tissue sarcomas? The reason it behaves differently is because not all margin positive people will recur, and margin positivity has doubtful recurrence. So if after first surgery, the recurrence risk is 50%, second surgery, the recurrence risk is 90%. And if you see, there are very few people who have undergone amputation in literature as compared to the people who are reported to have desmoids, because it comes down to the fact that some people have spontaneous regression or stabilization of the disease not requiring amputation. So earlier it was thought that the risk of or the odds of spontaneous regression are around 5%. However, it is probably under calculation, and maybe it's a tune of 20%, as I'll show in current studies. So there are few papers which have shown that what do you do when you do nothing, when you observe? What happens to these tumors? So this is how these tumors behave with time. And again, primary tumors, recurrent tumor, the x-axis shows time in months and y-axis shows ratio to initial size. As you can see, majority of the tumors, after wait and see, they stabilize after some point of time, and they don't even, I mean, hardly 4 out of 31 or 1 out of 24 patients kept on increasing, but rest of them, after some time, they stabilized. So this is one of our patient who came with features of intestinal obstruction, almost intestinal obstruction. It was subacute kind in June 2020. And we explained her everything, but they opted for observation. And after 1 year of and the scan, the image, the report was the change was desirable because it decreased to more than 50% without any therapy. Regarding medical management, conventionally, I mean, a few years back, tamoxifen and NSAIDs were used. NSAIDs are celecoxib, brufen, or Selindec. All these drugs were used. So it was thought that NSAIDs act to WNT pathway, which I showed you previously. However, right now, it seems that they don't have clear-cut benefit. They were used because of low cost, but they have low response rate. There is limited toxicity. So, but they're not very effective. And this was a study which was done in children's oncology group. They found that response rate of these agents was hardly 8%. So, and mind you, these treatment, they don't come without any side effects. Tamoxifen causes ovarian cysts in a lot of people. And yes, it causes other rare things as well. So, again, then came imatinib. So again, thought to be very effective, but RECIST response rates are poor, 6%, as compared to the available therapy. Imatinib is not very promising. And later on, they found that those tumors which have c-KIT or KIT mutation on next generation sequencing, these were the tumors which were more sensitive to imatinib. So in 2018, we had another option, and it's a great option which has opened up in recent 5 or 4 years. And it was a double-blind phase 3 trial. Total number of patients 87. Almost half were randomized to sorafenib and half were randomized to nothing, which is called placebo. And what they found that 2-year progression-free rate in sorafenib was 81% as compared to 36% in placebo. The objective response rate in sorafenib was 33%, which is quite high as compared to the previous therapies available. But the response rate in observation arm was also 20%, which is actually quite surprising, because in the arm we gave nothing. 20% is significant. And so a lot of people asked us that how much time does it require for sorafenib to work? And in this trial, the median time to response was 9.6 months. So I just tell them to have patience, because it might take 10 months, 12 months, 13 months, or as early as 6 months. But yeah, it might take some time for them, the tumors to respond. And it's not always size that decreases. So whenever a patient comes to us, or whenever a person comes to us with desmoid and he's on sorafenib, and we always ask for expert MRI review. As you can see in this case, there was a mass here, and after sorafenib, this whole mass disappeared, and this whole thing is fibrotic. This is called T2 hypointensity. And even though the size remains same, but the solid component, the cellular component disappeared. So that's what all the MRIs should be discussed with the expert radiologists, with the expert team, which are managing desmoids day-to-day basis. So this is our experience with sorafenib. And as you can see, we found that partial response was 46%. And similarly, we used 200 mg and 400 mg doses. We found that 200 mg doses was easy to continue. However, for 400 mg, a lot of people had dose reduction, almost 58%. And a lot of people, at least 10% people discontinued. So yeah, it's a toxic drug, but it's a mildly toxic drug and might be difficult to continue for forever. However, the partial response rate was 46%. So this is our clinic outcome, which was presented in ESMO 2022. What about chemotherapy? Though the chemotherapy has taken a backseat, however, the agents which are active are vinblastine methotrexate. Again, response rates are 40% and stability is 60%. Chemotherapy has those typical toxicities of chemotherapy, which might be hair loss, which might be vomiting, might cause neutropenia. So, and a lot of people cannot continue this treatment for 1 year. Similarly, there are studies in which has suggested again response rate 20-30%, but apparently it is felt that anthracyclines might have better responses as compared to methotrexate vinblastine. So this is one of our, when do we use chemotherapy? So this boy came to us around 1.5 years back, and he had large mass. He look at this mouth. He was not able to close his mouth. The mass was protruding. He was salivating whole time, not able to eat. We gave doxorubicin. We want response urgently. And after that, the tumor decreased. And since last 1.5 years, the tumor is keeping on decreasing by itself. And the child is coming now, and the mass is hardly visible. And he can easily perform all the activities. Similarly, a girl who came with big mass, neck mass, could not even keep her neck straight. We gave doxorubicin, and it had excellent response. Now this mass is almost not visible. These are abdominal desmoids, almost occupying whole half of abdomen. And then after chemotherapy, excellent, or more than 50-60% shrinkage. Similarly, look at this person who had almost whole abdomen occupied with desmoid, and after chemotherapy, it shrunk very well. And these responses are maintaining for last few years. So do we have another tyrosine kinase inhibitor just like sorafenib? Oral drug? Yes, we have pazopanib. And this trial was randomized phase 2 trial, but it was non-comparative because maybe the numbers were less. And they found that pazopanib also had 6-month non-progression rate 81% as compared to chemotherapy, which was methotrexate vinblastine 45%. And the responses were pazopanib were higher than methotrexate vinblastine. So this could be another option. However, a lot of times people ask why not include pazopanib as compared to sorafenib. So the easy answer is that it might cause graying of hair, graying of eyelashes, and discoloration of skin, which might not be cosmetically acceptable to many people. especially because it is a disease of girls. It might not be cosmetically acceptable. What about newer class of drug called gamma secretase inhibitor? So again, apart from WNT pathway, there is another pathway which is active in fibromatosis, and it's called Notch pathway. So there is Notch intracellular domain, which is usually cut from Notch receptor by gamma secretase. And once it goes into the nucleus, it causes increase of proliferation, survival, and increase of tumors and tumor proliferation of fibromatosis. So there are drugs which inhibit this gamma secretase. And this was a DEFI trial, which was presented this ESMO. And what they found that response rate of nirogacestat, which is one of the gamma secretase inhibitor, is 41% as compared to 8% in placebo. And the progression-free survival hazard ratio was 0.29, again significant. And coming to quality of life, there was improvement in global health status, improvement in physical functioning, role functioning, and there was also decrease in pain. So improving almost all the parameters. This is another gamma secretase inhibitor, AL102, which is there are two parts of this study, A and B. B is randomized part, and AIIMS is also a part of this study. And A is dose finding study, and the dose has been decided 1.2 mg once a day, and which is not affected much by food. And though this was not meant for the efficacy, however, we came to know that majority of patients are responding. And so at the selection dose of 1.2 mg once a day, at week 16, 9 were responding. And at week 28 of 3 patients, almost everyone was responding. So this is one of our patients in which we used AL101. And we thank Ayala Pharmaceuticals for this. And patient had excellent response and decrease in pain, decrease in limping. So as you can see, the lesion decreased all to almost half with increase in T2 hypointensity. So probably gamma secretase inhibitors and tyrosine kinase inhibitors are here to stay. And chemotherapy would be like when we want urgent responses, we want sudden responses, and either it's not responding to these drugs. What about local therapies? It's been a long time that we talk about cryoablation. Almost all the patients who ask about cryoablation and other RFAs. So cryoablation, this is one of the largest series, 34 patients, 41 desmoid tumors, and they studied cryoablation. And also, apart from reduction in tumor size, they assessed pain as from visual analog scale. They found that the pain was significantly less by visual analog scale. However, the tumor size was not very less. So the diameter pre-treatment, which used to be 5.8 centimeter, was after 6 months 5.6 centimeter. And the enhanced volume, so fibromatosis, we have enhanced volume, and we have hypointense, which is fibrotic part. So enhanced volume decreased by 50% from as you can see, the volume decreased from 87 cubic millimeter to 30 cubic millimeter. So yeah, but the drawback of this is it's not available everywhere. It's a very costly technique, and it might cause nerve injury. So in AIIMS, we have started using this, and I'm thankful to our intervention radiology, especially Dr. Shiva, who is doing this percutaneous microwave ablation for desmoid fibromatosis. And we were inspired by this recent paper in which there was 70%, there were 9 patients, and they found that there was volume reduction of 70% and the quality of life improvement in almost 90% patients. So the principle is simple like microwave. They insert a needle and the temperature increases and they cause water to run through so that the adjacent tissues, they don't coagulate. And this is how it's done. So this is one of our patient with abdominal fibromatosis. And as you can see, it's a large mass. Patient was symptomatic with lump and as well the bladder symptoms. And this is microwave ablation machine, and we did microablation. And as you can see, this is on day 10 of microwave. The whole tumor has become necrosed. So this is more for superficial tumor which are not in vicinity to nerves. And I think in next some few months or few years, we'll be more mature with our results of microwave ablation, thanks to our intervention radiology. What about patient-reported outcomes in desmoid? So a lot of time I have seen people trivializing this tumor that, see, this is a benign tumor. It doesn't metastasize, and why people are so disturbed. But yeah, they have a reason to get disturbed. This is a lifelong disease. It it has waxing waning course, and it's a painful disease, might cause functional deficiency. So we ran this study in All India Institute of Medical Sciences. There were 102 people, and we found that anxiety and depression were there in 40 and 50% of people respectively. And as you can see, we compared them to healthy controls, and we found that they had significant higher level of fatigue, pain, insomnia, and financial difficulties. Simultaneously, their physical functioning, role functioning, emotional, and social functioning was significantly lower as compared to healthy controls. So it's not that trivial. People living with desmoids have difficult life, and some equated as in other metastatic cancers. So we have discussed almost every aspect. So what I will like to tell everyone, especially my students and people whom I treat, that pathology and molecular testing, pathology is mandatory, should be mandatorily good, and it should be the pathology should be proficient before labeling it as desmoid tumor. Molecular testing needs to be done whenever possible. Active surveillance is the first management. However, surgery might be reserved for abdominal wall desmoid in upfront setting. So chemotherapy, sorafenib, pazopanib, these are the drugs that are existing with us. We usually, chemotherapy takes a back seat, sorafenib, pazopanib take preference, and gamma secretase inhibitor, the data, DEFI trial and AL102 trial, the results, whatever results are available is promising. And cryoablation is a good thing if it is available in whatever places. However, we in AIIMS are doing microwave ablation, which might be much cheaper than cryoablation, might be as effective. We don't know, data needs to be there. The people we treat with desmoid have high level of anxiety and depression, and their quality of life is a bit jeopardized, and is almost as jeopardized as in cancer patients. So we should be sensitive in dealing with them, and including the psychological issues. Thank you. So I'd like to thank all my medical oncology colleagues, surgical oncology colleagues, orthopedic oncology colleagues, radiology colleagues, pathology colleagues, and desmoid management is a team effort. And thank you to all our people who have made us wiser over the years.